Professor Ducreux, thank you for joining me to discuss about gender medicine. A lot has been done in other medical specialty like cardiology. Why still not so much in oncology?
I do not understand, in fact, because this is something that is very, very interesting, and now we have some data that are proving that it is of great interest for oncology. Probably because the disease is so severe that when we saw some discrepancies between male and female, we consider that to be linked to hazard or something like that without any clear explanation. So we did not consider that either for efficacy or for toxicity.
Despite increasing evidence that sex is a major factor influencing chemotherapy, toxicity, and possibly efficacy, it is usually not taken into account in clinical decision making. Isn't it surprising in the era of precision medicine?
It is completely surprising because we are trying to focus on to target specifically something when you are treated patients with multi-kinase inhibitor, and we do not look at all on something such important as differences in terms of toxicity between male and female. So I think it's clearly a pity, and even in our clinical practice, if we could consider that, for instance, for alopecia, it is higher in female than in males. When we are speaking about toxicity of our regimen, we have to know that, because if it is 60% for females and 30% for males, we have to say to females, okay, the risk of alopecia is 60%, and not to give a mean number of 45 or something like that.
Mm-hmm. And actually, most clinical trials do not report any result by sex. However, in 2015, the FDA recommended to systematically analyze sex differences. Do you think that subgroup analysis according to gender should be mandatory in clinical trials?
Mandatory, maybe it's something that is a little bit difficult, but I would say that it could be very useful for us to know exactly the toxicity and the efficacy according to gender. And as I gave you the example of alopecia, for any kind of treatment, multi-kinase inhibitors, we have to know if there is some discrepancy in terms of tolerance between male and female. And I am sure that in some example, probably the efficacy is also different. And when we see a difference in terms of efficacy in a forest plot about sex, we always say, I have no explanation. So I do not speak at all about that. And this is a problem.
And all in all, gender medicine remains a neglected area of medicine. How can we increase the attention of our scientific community on this issue?
I think that to have some reports such as yesterday here in Munich with a presentation of the results in esophageal cancer about the toxicity on a lot of patients taking together different trials to show that the toxicity is different between male and female is the first step. And there is also a workshop that is led by Dorothea Wagner and that will take place in Lausanne on the 30th of November with an ESMO workshop about gender and oncology. And this is something we have to continue, I would say, to communicate on this problem. It's very important.
Thank you very much, Professor Ducreux.
You're welcome. Thank you.